Good afternoon once again. I think let's get the show rolling. Um, Good afternoon and welcome to yet another seminar from the Department of Family, Community and Emergency Care, FACE. I am extremely excited to present to you what is to come. Let's start with the topic. Emergency medicine will be presenting a very interesting project, how we are developing clinical decision tools for pre-hospital providers. And the people, Associate Professor Peter Hodkinson, an academic with many hats, the cornerstone of our division of emergency medicine, and also a PhD graduate and the convener of the MPhil program. And on the other side, Sandy Picken from the Knowledge Translation Unit will also presenting a part. I'm looking forward to this presentation. Let's keep the questions for afterwards. And I have asked permission or consent to record this session as well. So please just respond to that. Over to you, Peter.
Thanks, Clint. I'm not sure how I feel about being called the cornerstone. I'll digest that one. Yeah, thank you. I had my arm twisted a little bit because I wasn't sure if this project was quite mature enough to present, but I actually, having thought about it, I think we could really get some valuable input from the department and also just a bit of insight what we're doing, and particularly the Knowledge Translation Unit is a real asset in our midst, and we're excited to be learning with them. And I think there's a lot to be taken beyond this. We have not just pre-hospital, but we have an emergency guidance document which needs an update, and maybe this is the space from there. Okay, so this is a project we've been planning for the last 18 months. Was actually stimulated, well, is driven by the HPCSA. They put out a bid for this project, and we have put it together. The core team is myself, Willem Stussen, and Wesley Craig. But we've pulled the whole division in. This is a division-wide project, and in collaboration with the Knowledge Translation Unit, and we have Dr. Sandy Picken on the seminar. She's going to be talking too and telling us a bit about what the Knowledge Translation Unit is. Okay, just to check my slide is advancing, I think it is. Just to give you a bit of background, sort of talks to the history of pre-hospital medicine in South Africa a bit, so I don't want to go too broad. But what started off probably in the 80s, formally with short course training, and then became diploma courses in the 90s. And around 2000, the degree courses started. And these were all driven largely by somewhat informal algorithms and more by drug lists. And they were very scope driven in what drugs they could use for exactly what condition and under what circumstances. So it was kind of pushed in 2015. I was part of a group who developed a clinical practice guideline, which was an attempt at bringing real evidence in, international evidence, to support the profession. I'll show you some more of that now. But it did and it didn't work, in that it's a big, unfriendly, voluminous document, and at the time we knew that it needed translating into something for the end user. So that's what we're busy doing now. So just a little insight into what the clinical practice guideline looks like. It's a 200-odd page document, and it's full of evidence statements, and very beautifully methodologically sound evidence-based statements, with the sources and transparent methodology. And I'm only really learning now, that kind of 8 years after putting this out, just what a change it has made to the profession. But it it's really not friendly and it's not usable by the end user, and it's taken a lot of translation happening in different ways around the country. We find that all sorts of educational institutes have made their own little handbook from this, and it's not very standardized. For those of you not deeply involved in EMS, just a little bit of insight, and I find this very confusing, and I get corrected by my colleagues every time I try and write it out. But there are a confusing number of scopes of practice within pre-hospital medicine in South Africa. We broadly tried to clarify them into just 4 levels, which is the way we're going to go for this project, which is the basic life support BAA, which is the backbone of the service. I think something 70–80% of the EMS crews in South Africa are there. And then the bulk of the balance would be what we broadly call intermediate life support, which would be the green category. And this CPG has a controversial kind of tick box thing over what exactly each scope can do. So that's one of the complications of what we're doing. So to skip from there, what the need is, I've alluded to already. We have this voluminous CPG. We need to put it into a user-friendly tool. The tool needs to be patient-centered, evidence-based, and possibly the point where I want to go on this seminar is it needs to drive a continuum of care across the South African health platform. So we want what we are telling pre-hospital staff to do to link with what the in-hospital needs and processes are. The challenges are we're basically being asked to rewrite the profession in a year on a small budget, balancing the detail with solid approaches, prioritizing the topics, and that's been a challenge. Some of the approaches are novel. You'd think they'd be out there and you think they'd be in the international literature, but they aren't. And even where they are, they've got to be contextualized to South Africa. The 6 levels of providers I've already alluded to. Some of the evidence is needing a bit of an update. 2015, 2016 is when the prior searches were done. And as I've just said, considering the patient, the various providers in the healthcare system. And finally, this needs to be a transparent process with buy-in from across the country. The implementation of the CPGs was not without its issues and is still somewhat controversial, largely because of the way it was implemented and put out to the profession. So we're hoping that'll go better this time. So I'm going to pause there and hand over to my colleague, Sandy Picken, to tell us what the Knowledge Translation Unit does and how they're coming into this project.
Great. Thanks, Peter, and good afternoon, everyone. Thanks very much for having us on today. I am busy on this project with my colleague, Dr. Ruth Cornick, who sends her apologies. She's on leave this week. But yeah, I'm going to give you just a brief overview of the Knowledge Translation Unit and developing clinical decision support. I recognize many names on the list of participants. So some of you are very familiar with PAC and our clinical decision support. So bear with me, I'll try and be brief. Okay, you can advance. Thanks, Peter. So basically, the Knowledge Translation Unit, or the KTU, is a health systems research unit. Our interventions are focused on providing support for primary healthcare workers in low resource, high burden settings. By translating the latest evidence and policies into practice, our overarching aim is to bridge the gap between what we know and what we do. And essentially, we use clinical decision support tools as the vehicle to achieve this. Thanks, Peter. You can move on. So the KTU has 2 homes, one being the Department of Medicine at the UCT or the University of Cape Town. A lot of our research is channeled through this home, as well as providing services like ad hoc lectures and this sort of work, the clinical decision support mentorship work. The other home is at the Health Foundation of South Africa. This is an NPO set up with the support of the Western Cape Department of Health to responsibly channel funds to priority projects. You can move on. So the KTU is divided into teams. They comprise those of us who focus on developing clinical content. We have 2 teams that look at training and at implementation. We have a design team that comprises graphic designers, as well as a new doctor there who will be leading on our digital innovations. We're a health systems research unit, and so we have a research team as well. All of our teams are supported by our finance and admin teams, and yeah, we all work quite closely together to develop the programs and evaluate them as we go. You can move on to the next slide, please. The core program that we have in the unit and that we've spent the last 20 years developing and evaluating and implementing is called PAC, which stands for the Practical Approach to Care Kit. It comprises a guide, essentially a clinical decision support tool, training curriculum, and includes health system strengthening and monitoring and evaluation components. These monitoring and evaluation, it's something that happens within the system as the program gets implemented, but also in parallel, we've conducted randomized controlled trials and process and economic evaluations alongside the programs as they've been implemented. If you just click, I'm going to be focusing on this one, the clinical decision support aspect used in our guidelines for the purposes of today. Okay, can you move on, please? So the process of knowledge creation and distillation can be described in a pyramid form. At the base, it is knowledge inquiry or the first generation knowledge creation, which is where your primary studies like your RCTs exist. This knowledge is then synthesized into a second generation body of knowledge, and this is where all your systematic reviews and your clinical practice guidelines are. And these can be further tailored into third generation knowledge products or tools. And these are packaged and presented for easier use. And these include your clinical decision support tools and algorithms and checklists. And if you click on it, and these are the projects that the tools that we specialize in. If you go forward, please, thanks. So just to describe PAC a little bit more, PAC is essentially a clinical decision support tool, and you'll see the one on the left there is the one that belongs to the Western Cape Department of Health. And as I mentioned, we've worked closely with the department and a lot of stakeholders and clinicians over the last 20 years. It's been a very consultative development process, and it's been developed and refined for a long time. On the right there, you can see the South African National Department of Health has also used PAC as well, but they've renamed it to Adult Primary Care, or APC. And this has been absorbed into the department's Ideal Clinic initiative as one of their key clinical components. So we work closely with both these departments to update these guides on a regular basis to keep track of local policy changes and updates. You move on. We are expanding PAC suite of tools to address a life course approach with PAC Child about to be released and PAC Adolescent still in its pilot phase, forming part of a trial. You move on, please. So we've also landed up working with ministries of health beyond South Africa's borders. You can see here PAC guides for Botswana, Nigeria, Ethiopia. We have a Portuguese version for Brazil and a Bahasa version for Indonesia. We've also been working with the WHO to adapt the PAC guide to become a resource for primary care training in the WHO Academy. Moving on. So the aim of the PAC clinical decision support tool is to really address the needs of both the patient and the provider in a primary care setting. And largely our tools are used in the context of consultations, so whilst seeing the patient, point of care. Just to mention that our tools are currently used mostly in public sector settings. And just one of the bits of feedback we got from a nurse working in a rural primary care facility is that she regards PAC as a tool for every day, for every patient. And I thought it was just to include that, as it sums it up quite nicely. You can move on. So PAC clinical decision support tools. To introduce you to some of the features of PAC and essentially any clinical decision support tools. PAC is designed as a comprehensive tool for primary care use, and so necessarily it includes over 500 symptoms, syndromes, diagnoses, and conditions. And it really aims to integrate all this information so that it can be used at point of care. The content is both evidence-based, but also aligns to local policy. And notably, it uses the patient's presentations as a starting point. So it's therefore symptom-based and syndromic in its approach. So it leads the clinician to making diagnostic decisions and management plans. We've also done a lot of work to make sure it's easy to use. And so some of the features of clinical decision support tools, and this is really the work we're doing now with the EMS team, is to take the clinical practice guideline content and to reorganize it into an easy-to-use format using algorithms, checklists, step-by-step instructions. So we use certain design features, which I'll show you in a moment, and a standardized format that makes it easier to navigate for the user. A lot of the work that we do is to make sure that it's written in a simple and concise way that makes it accessible to the least experienced or least qualified user. Okay, you can move on. Thanks. So just quickly to take you through some of the features of PAC, as I said, it's simple symptom-based. So the first half of the guide, which is about 180 pages now, contains symptom-based approaches to each one of the symptoms that you can see there. Sorry, they're a bit small. You move on. The second half of the guide focuses more on chronic conditions and having a standardized routine approach to each chronic condition. If you move on, I'll give you an example of a symptom-based approach page with an algorithm that helps the clinician with a structured approach to a consultation. You'll see it shows the structured design feature of using a red box to define those needing urgent attention and referral. This is followed by an algorithmic approach for those not needing urgent attention. So unlike a textbook layout, the algorithm incorporates relevant elements of the history, examination, the tests, the health education, appropriate screening for chronic conditions. These are all integrated into the relevant steps of the algorithm itself. I'll show you in the next one. We zoom in a little bit. And you can see that if they don't use the red box, they'll follow the relevant pathway through the algorithm. Moving on to highlight some of the other features I mentioned of how we try and standardize the way it's laid out. There's the red box again for urgent issues, and in the routine care side of things, we use an assess, advise, and treat framework to structure a routine care consultation there. You can move on. So I think relevant to the process that we're embarking on now with the EMS team, PAC provides an opportunity or a platform really in both its development and the maintenance of the program to support health system strengthening. And some of the examples you can see over here on the slide. So it helps to coordinate care within a facility or a team. Amongst other methods, it uses color coding to facilitate task sharing and clarify scope of practice. It's useful for streamlining and standardizing referral pathways. It helps to rationalize the use of resources like tests and medications. And it often helps to resolve policy inconsistencies and gaps. It it's very good for identifying those gaps. And then moving on. So what role is the KTU playing in this project? We are essentially mentoring the development process of the clinical decision support itself for the MS team. We're helping to determine the standardized structure and design features. We're helping to guide the mapping of the topics and the integration between them, providing some clinical editorial input, as well as some support on the project management side. And our graphic team, design team, will design the finalized content. And if you go to the next slide, that's really all from us, and you can find some more information if you need on our website. Thanks.
Great, thank you, Sandy. That was great, and every time I hear you guys talk about what you do, it sounds better and sinks better. I think you can all see the parallels to what they've done with PAC and dealing with the different levels of providers in the primary healthcare space, from the community health worker up to doctors, and very much what we're dealing with BAAs with 6 weeks of training up to 4-year degrees paramedics. Yeah, and I can't help but think of the potential. We've got our links with AFEM, and this has the potential to spread and lead up the continent and elsewhere. It's not going to be comprehensive. This is a first go at it, but in the long term, it has the potential. Okay, so our plan for this project, which is just a year long, is to develop 24 clinical decision support tools. It will likely end up as more than 24. 24 is what we've contractually agreed to develop. And this is being done primarily by our core UCT EM team. But we're pulling in all the divisional staff, students with specific skills and knowledge bases, and colleagues, and we might be knocking on the door of many of you. As well as you've heard the knowledge translation unit, and we're learning hugely from them. What on first appearance looks like a straightforward approach, and you look at PAC and you think this is simple, and then you start looking at the detail and the way they've thought it through, and we're starting to slowly think their way, I think. Although we haven't finalized the first 3, which we've been bouncing back and forth between them and us. Hopefully it'll go faster once we're on the same page as them. We also have an advisory board, which we formed, and that's quite an eminent team from across South Africa. We've got high-up management representatives from public sector, various provinces around the country, private sector, the big services, and the national department as well. And still to be formed is what we're calling a super user testing group, which will be various cadres of pre-hospital users and to actually play with our algorithms and test them and give us feedback. So very broadly, we're sort of contractually bound and still playing around with the specifics, so I can't give you the absolute details, but our topics that we're planning are around these: the general approach to shock and a bit of the different types of shock, the airway in danger, and that will be the topical one, and dealing with the different scopes and to intubate or not and how, and ventilation, difficulty in breathing, and we're going with a symptom-based approach there. Struggling a little bit dealing with the different approaches, but I think that's going to be an exciting one. Chest pain we've already delved into, and is broad as it can be, from any chest pain presentation down to thrombolysis, which paramedics are allowed to do. The fitting patient, confused or aggressive, loss of consciousness. The injured patient, and there's a lot of sub-tools we're planning, we're already thinking through. Pain is a topical issue in pre-hospital, and we're planning on tackling that one. Various pregnancy-related complications, and we're looking at eclampsia and PPH primarily. Poisoning is likely to be a general approach, and then probably pediatric diarrhea and vomiting. Those are the ones we've settled on, but we're still negotiating the details. In essence, the process will be, we'll select a topic, we'll go through a rapid review of the evidence, starting with a CPG and then looking for recent kind of systematic level updates and any other specific updates we're aware of. We'll draft the tool. There's a back and forth review and refining largely between the KTU experts and our team. We'll then put it out to clinical experts for review. And we're asking for anyone to put up their hands, or we'll be approaching you. And then refining it from there and end user testing as I described. So that's pretty well all I wanted to say. Just before I forget, Jeroen asked anyone who wants CPD points just to put your HPCSA number in the chat, please. Yeah, so we would open it to discussion from there. What we were specifically hoping for, just to kind of guide the discussion a little bit perhaps, is insights from those of you who are using the PAC tools on a daily basis and have some insights. From the clinical colleagues working in receiving emergencies and receiving from EMS, any specific gaps that you think you identify in EMS practice, knowledge and skills, and we're not opening it up to grievances with EMS, let's not go there, but things that you see as a real disjunction between the way EMS does it and the way patients get dealt with in hospital, and where there seem to be inconsistent and a lack of guidelines for EMS staff. We've got a few final topics we're still teasing out. We'd welcome some input on those. And then anyone who's interested in participating, very happy to have you on board. Okay, I'm going to stop the presentation so that I can see faces in the chat. But yeah, please, anyone with any input is welcome.
Thank you, Peter and Cindy. That was amazing. We're going to move over to questions now. Either put your hand up or post it in the chat. And then we take it from there. Willem, your hand is up. Thank you.
Great, thanks, Clint. Maybe I just want to make it clear that the current exercise is not intended, or never mind, not intended, will not have any influence on scopes of practice or what medications can be used and so on. It is not the mandate of the clinical decision support tools to engage with that whatsoever. That is the mandate of the Health Professions Council. But this rather seeks to take the evidence and move it into a workable, usable solution that the clinician can use at the bedside. So I just wanted to also just clarify that. That's all. Thank you.
Thank you, Willem. Steve?
Thanks, guys, for excellent initiative. I want to, and thanks, Sandy, for setting out the PAC side of things so clearly. I know that you have a PAC community that is aimed at community health workers, and I wonder if you could outline the intersection of these guidelines with the PAC community. From the list of topics that Peter's just outlined, obviously the acute care issues, which are often just the surface of chronic problems that people struggle with at a home level. And as you know from the Pathways to Care study, family members were often struggled to decide whether a child or an adult or whoever was ill enough to actually call somebody to get help, etc. And those decision-making processes at a home level, outside of a facility, way away from any services, are actually the most crucial. So that's where community health workers have a role. And my question is, how do these guidelines intersect with what you've already written and put out there for community health workers?
Thanks,
Steve. You want me to start there, Clint?
Please go ahead. Yes,
Okay.
please do.
Yes, a version of PAC Community exists. It is in the form of an A5 size bookie. It was called colloquially named D-Bookie, but it has a limited scope of content that is targeting chronic conditions like hypertension, diabetes, asthma, epilepsy, TB, and HIV mostly. And it does articulate with PAC adults. So there are prompts within PAC adults that say if there are things like adherence problems or newly diagnosed chronic conditions, it refers the clinician to refer down to a community health worker and to sort of close the loop on referral requests. We are busy. That hasn't been expanded or adopted by the Western Cape as a program going forward, but we are involved in, currently at the moment, we are developing, our training team is developing a community training program for community health workers that spans both the rural Ukupela and the metro side of things. So it's standardizing a Western Cape version of that. In terms of how it might integrate in terms of identifying those patients who a community health worker would need to assist home personnel to call an ambulance, I think that's quite a valuable point. We could look at building in prompts into the training around, so a lot of the training will be around identifying danger signs and when to seek urgent care, and I think this could dovetail quite well with that. So it's definitely something I can take forward and try and build into the community health worker training of when to seek urgent attention, and if you can't actually make it to the clinic on your own steam, when to call an ambulance and a pre-hospital team. So, yep. I'll take that forward.
Yeah, just to follow up that a lot of the acute conditions are in fact acute on chronic. And so that link needs to be made explicit in the Red Cross study that Peter was involved with. There was a lot of indecision or difficulty in making decisions at a household level as to when to seek care. Obviously in children things develop much more rapidly, so the timeline was shorter, but nevertheless, people delayed for ages, vacillating as to whether to call the neighbor or the auntie down the road, or wait till the father came home, or or they tried the clinic and they had to wait 8 hours and they went home again. All those sort of stories that need a guidance that has the framework of the household rather than the framework of the clinic or hospital as the unit of understanding. Yeah, that's
sure. I hear you.
It's quite a fundamental sort of different framing of the issues. That's all I wanted to say. Yeah.
Thanks. Great. I will capture that.
Peter?
Yeah, likewise. I think that's a great concept, what Steve's alluding to, and something to think forward to. But it also makes me think of the EMS call centers and dealing with that decision. At the moment, as I understand it, EMS is pretty well mandated to plan to transport anyone who calls. They can't really turn them away. They can suggest they go somewhere else, but yeah, they need clinical tools like this to advise the person on the other side of the call. So yeah, lots of scope.
Sorry, just to add, during COVID, we did create something called Pack Home, which looked largely at public health messaging around chronic conditions. And it's something that's potentially a layer, so that's still being developed and refined, but it's something that we could potentially add a layer onto in terms of when to seek care and how urgently. So yeah, we'll brainstorm around that. I like that idea. Thanks.
Thanks, Steve, Sandy, and Peter. Any other questions? Are we waiting for questions? Peter, timeline-wise, what do you have in mind, or what do you envision? All goes according to plan.
Well, our contract, as we've agreed with the HPCSA, is to have the 24 tools delivered by the end of April 2024, which is quite a tight timeline. We're hoping that once we get into the picture of what these look like, it'll speed up. At the moment, it's been a bit slow for the first few. Yeah. I'm keen to hear from the family medicine, primary healthcare colleagues out there using PAC every day and their insights. And EM colleagues, ideas about specific clinical conditions, perhaps, that where you feel that there's a disjunction between what EMS does and what you do and how you want the patient to arrive? Okay, we were scared this was going to turn into an EMS grievance session, but obviously you're all completely happy with what EMS does.
Maybe, Peter, I'm just filling the gap. Tell me, how do you think this will affect? Oh, there we go, Maggie. Maggie, please go ahead.
I know if Renee was here, she would have wanted to ask something about palliative care. Is there maybe something in when not to intubate, or prompting people to think a little bit further? Because obviously I now only see the bad side of things, the wrong side of things, and patients lying in ICU for very, very long without anybody thinking further than keeping alive and thinking of how's discharge going to look like? What is it going to look like for the family? What it's going to look like for the patient? Is it possible? Yeah, I'm more to those kind of things.
We'll let Willem take that one.
Thanks. So, Maggie, maybe just to answer one part of your question is unrelated to this project. We're also, through a series of other studies, trying to understand decision-making around resuscitation and withholding and withdrawing resuscitation for EMS in general. And those are a couple of studies that are currently ongoing, because it is very difficult for the pre-hospital provider to make that decision at that exact moment, because it actually is a systems and a justice decision or distribution of resources decision versus always a clinical decision at that point. So we need to create termination and non-initiation of resuscitation guidelines outside of this project. That answers the one part of it. But we also have what was not on the list, and it goes sort of in some of the other parts, is we are planning a palliative care algorithm or clinical decision support tool process that's not going to, probably not going to guide decision-making around when to initiate and when not, but will help to guide decision-making in a patient with palliative care needs. as an example. So there is that element there, and that's in the second phase of the work, which is only after October. But there's certainly an intent, and we've identified the gap there that EMS does not do palliative care very well. So not actually answering your question around making the decision, that's a bit more work than what this will allow, but we are definitely including palliative care decision making in this. Yeah.
Great, thank you. And I must say this is probably some of the most difficult decisions to make, especially if you're alone. So yeah, I'm not I'm not criticizing, I'm just mentioning it, and I'm glad to hear that. I know that we are also involved a bit in PAC, and we've given 1 or 2 scenarios, so it's great to hear that there will definitely be an interaction with EMS and palliative care as well. Thank you.
Thanks, Andy.
Sounded like a hand going up to be an expert.
That's what I also interpreted from there.
Thank you. We've got 2 comments, one from Beverly Schweitzer to say how she valued PAC and the value it has had in her area. And then important comment from Steve as well. How it's a bit concerned about the assumption that every complaint needs a referral into the system, as opposed to empowering the people to choose, which is a very important comment.
Clint, maybe
would you like to comment on that, Willem?
Yeah,
Sort
maybe in response to your comment, Steve. So it's called unseen discharge in a way from an EMS sort of language perspective, and some of the EMS providers have unseen discharge on their scope of practice. Currently, as it relates to the evidence to provide unseen discharge and that kind of a decision making, frankly, just does not exist currently within the emergency medicine, pre-hospital emergency case space. Now, this is also something that we are working on around when is it safe to discharge a patient unseen, etc. But for the moment, we are not doing unseen discharge as a decision-making algorithm here. That will be up to the discretion of the clinician in which scope of practice it would fall. But agreed, we need to think about that. And especially from a larger systems perspective, one of the biggest issues, at least in my view, around unseen discharge and so on, is that in order for that to occur safely, especially considering that someone has actually initiated an emergency response, in order for that to be done and implemented safely, we need a safety net or a follow-up process or some other mechanism to ensure that when it was done erroneously or when there's an escalation of the person's condition, etc., that there's a way to follow up, including when we implement these kinds of things, evaluation and a monitoring mechanism to make sure that the decisions that are being made are not in the worst interests of the patient. So also definitely something that we will work on, but there's obviously all of these other elements of the system that we will need to just think about for that implementation. And I think it's based on that, on those complexities, that it's not, well, firstly, no evidence, other elements of the system, and needing to have these evaluations and assessments to ensure patient safety is kind of why we're not focusing on that also in this iteration, but absolutely taking your point around the fact that needs to be addressed in an EMS system specifically.
Just to summarize what the conversation was about the last 5-10 minutes, there are 3 areas of interest that we don't have all the evidence about, but a lot of things are happening. And the first area is at home, decision making at home. What are the options? Number one, we know we've got limited options for health care. But how do they make the decision? When do they call the ambulance? When do they decide to go there or call the auntie, etc.? So it's home decision making. So that's the one field. And the second one is once they've decided to call the ambulance service for help, how does that prioritization and triage work? So that's a field where there's a lot of work going into call prioritization, triaging, etc. And then the third one is the on-scene discharge. Once the ambulance personnel has been dispatched to the scene, when to do. Those are the three fields that we've identified. There's a lot of work happening on those fields, and I agree with Steve. We do, even though this clinical decision tool won't solve all the problems, from billing to coding to medicine list to evidence, etc. There's a lot of things that we want this tool to solve. It won't solve all of it, but I do think that linkage between these is important. Yes. We've got a comment from Maggie. Please go ahead.
Just interestingly enough, I was very fortunate to be able to attend King's College last week in London, and they had a very interesting research they did and talk on the use of ambulance services by their obviously by the public, and they have a system where the paramedic many times arrive at the patient's home or telephonically speak to the patient and the family, and then advise them to rather go to the clinic tomorrow morning or do this or book them an appointment, or to not take them to the EC but to take them somewhere else. They also have the system where the paramedic on scene, or they can phone a doctor for advice as well. And they actually had quite interesting stats on patients in the end that was not transported to hospital or to the emergency unit, but that was, and they actually had quite good outcomes. So I was quite surprised. So I don't know if that is worthwhile looking into that, and I'm not sure if that's even a possibility in South Africa, but it was just very interesting that I actually had a talk on this just last week.
Thank you for that. Peter.
Just a comment, because no one seems to be coming in, but something interesting that's coming out is several comments about PAC being used for training and being used for students. So we've debated kind of the use of this tool, and I think the primary perception is it'll be a bedside roadside tool, and we're thinking of an A5 booklet that'll be sort of 2 A5 pages opening opposite one another. But there's no doubt it's also rapidly going to be assimilated into training, and probably a bit more uncomfortably, but it was alluded to even by the HPCSA team. It's going to be medical legal and used in that purpose, which puts a weight on us. But yeah, it's quite exciting how it could change things.
Just hi, Lauren, I see it. I'm just thinking of all the comments as well. One thing that we've noticed is that there's significant variation in practice across the provinces. And there's significant variation in resources and systems. And the tool is aimed to have one guideline across all provinces, and it makes it very difficult. Things like palliative care systems. We know in the Western Cape, there's the palliative care network being established. In some areas, it's absolutely amazing. In other areas, it's being established, but there are certain parts of the country who doesn't have it, etc. Backup systems, very important. Access to other health systems, the other health care facilities, etc. So all of those things play a role in the decision-making process, and it makes it extremely difficult. Lauren.
Thanks so much, Clinton. Actually, I think your comment is the foundations to my comments that I was going to make as well, which is that much of the discussion and the feedback, the comments, the questions that have come through this afternoon speak to access and pathways to care, even though the clinical decision support tools don't specifically relate to access pathways, there's certain assumptions that we would have to build into the readiness of a system to be able to integrate this kind of clinical decision support. And so the question really is, what would be our thinking around the minimum requirements of a system's readiness to adopt a clinical decision support tool like this, particularly as it relates to resource limitations, whether that be geographical distance in terms of access to care, access to transport networks, or access to clinical resources. And that is in relation to the context in South Africa, but certainly from another perspective, with the work that we do within AFIM, is variation in terms of EMS systems on the continent. It's not so much a question, more a comment. And I think this is an area that's really interesting for us to explore. And certainly we're going to, I think, appreciate a lot of insights, observations, and reflections through this process. Thanks very much.
Thank you, Lauren. And I think what we're talking about, standardization and care pathways and care packages, all these terms, it's a very relevant, those are all relevant topics considering the recent developments with the NHI as well. And I'm in no way saying that there's a link between this project and the NHI, but it's something that is certainly being pushed from a national level, standardization from always on all platforms. Willem, do you want to comment? Do you want to just summarize your comment and the problem statement and the comment that last?
Oh yeah, sure. So just around the
Thank
decision, just around the decision making of in the dispatch center. So almost universally, the I can actually go on about this for a long time, so I'm gonna resist the temptation. But all across the world, the triage algorithms that are implemented, or clinical decision support algorithms that are implemented in dispatch centers across the world, are incredibly inaccurate. Most of them, however, lean towards over triage, which means that it rather errs on the side of utilizing more resources and sending ambulances with an emergency response. This has a series of different consequences, which I'm not going to go into that. I can talk forever on that. But the point is that, and also these algorithms are not seated within the language that we use and the way that we speak about our own diseases and so on. So, or our own presentations and what the emergencies are. And it also doesn't speak to a system where public transport is not available, and so on and so on and so on and so on. So there's a lot of other complexities from the health system, more largely like infrastructure and so on, that influences the way that we need to think about telephonic triage and so on. But we are actually, it's basically my research field. So it's exactly what we're trying to develop at the moment and understand and things like that. So there's a lot of stuff happening there, but it's just taking a bit longer than what it would have been, what it could have been. So anyway, that was just a little comment, and it's something I can never actually resist to talk about. So sorry, it's just too tempting.
Well done, Willem. That was very good, very short, much shorter than I anticipated. I think there's time for one last comment or one last question before we close. I think we had a very rich discussion, and despite the project, we've also spoke about 3 gaps that's in the system, and we've also learned about all the good work that's happening behind the scenes to address these gaps. And I'm sure we all want equitable access for all our patients. And it's a slow process, but things are happening behind the scenes, and it is very inspiring. If there's no more questions, I'm going to, Peter, allow you to say the last few words, and then we can close.
No, thanks, Clint. Yeah, thank you all for joining. See, there's some powerful people on the call. We had the Deputy Dean, we had the head of Western Cape EMS. So yeah, please talk to us all privately if you've got any further input. But yeah, we feel like we've got you behind us.
Thanks, Peter. Thank you so much, Peter. Thank you so much, Sandy. And with that, bye-bye, everyone. The recording will be available for you.
Bye-bye.
Bye. Thank you.
Bye-bye. Thank you. Cheers.
Bye, everyone.